And welcome to the Adverse Childhood Experiences Among School-Aged Children webinar. My name is Shamika Davis, and I'm a program manager at the School-Based Health Alliance, and we are glad that you are here with us today. The School-Based Health Alliance is a DC-based nonprofit founded in 1995 and serves as the national voice for school-based healthcare. Our focus includes policy, standards, data, and training to support and grow school-based healthcare, particularly school-based health centers. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack equitable access to healthcare services. School-based healthcare is one solution, bringing healthcare to where students typically spend the majority of their time in school. When schools, families, students, and the community work together, students win. I would like to share with you a few reminders for today's webinar. All attendees are in listen-only mode. To ask a question during the webinar, please use the Q&A icon of your Zoom control panel. Closed captioning is enabled for this webinar. To turn it on, please click the CC button on your Zoom control panel. At the end of today's webinar, we invite you to complete an evaluation. Your responses are important for helping us to understand how to improve our work. And also, a copy of today's presentation slides and recording will be available on the School-Based Health Alliance website and the Health Center Clearinghouse resource website in the upcoming days. The learning objectives for today's Adverse Childhood Experiences webinar are participants will be able to define adverse and positive childhood experiences and give 2 examples of each, explain how experiences affect our brains and bodies across the lifespan, to describe trauma-sensitive inquiry, to give 2 examples of activities that enhance positive experiences or mitigate the impact of adverse experiences. I am happy to introduce our presenter for today, Dr. Audrey Sillerman. Dr. Sillerman is an integrative family physician and clinical associate professor of family and community medicine at the University of Illinois, Chicago. Dr. Sillerman is medical director for the Miles Square School Health Center program. She leads the clinical work of 5 school health centers offering integrated medicine, medical and behavioral health services. Dr. Sillerman serves as a clinician, educator, researcher, administrator, and activist. Since 1991, Dr. Sillerman has provided compassionate, holistic care for families across multiple community-based public practice settings while advocating for equity. In her additional training, Dr. Sillerman has training in family therapy, mind-body medicine, mindfulness, transcendental mediation, and trauma-informed care. In 2019, Dr. Sillerman was named one of 50 notable women in healthcare by Crane Chicago Business, and in 2020, a top Illinois family physician by Marquis Who's Who. Dr. Sillerman is a community resilience model ambassador and phase 2 certified neurosequential model of therapeutics teacher. Dr. Sillerman is co-founder of the Center for Collaborative Study of Trauma, Health Equity, and Neurobiology, an advisory council member of the Illinois ACEs Response Collaborative, and advisor for the Partnership for Resilience. Dr. Sillerman is the proud mother of 2 beloved daughters. I now welcome Dr. Sillerman.
Thank you so much, Shamika, and thanks everybody for joining us today. It's wonderful to be with you. I'm just going to take a minute to share my screen and then we'll get going. Okay, let me get us to the beginning. Okay. Hello. Okay, this is me, and this is what we're going to be talking about today. We're going to talk about the impact of childhood experiences on health and how this science can really guide us in our work of caring for children and families. So I want to give us a little reminder that trauma and actually all experiences are personal for us. And we're going to be talking about some difficult material. We're also going to be talking about some things that might not have been a part of our training. Certainly they weren't part of mine. And sometimes these kinds of contradictions and conceptual dilemmas can be very uncomfortable. And so I'd like to invite you to browse around our website at the Then Center for some materials, or if you need to just take a break and come back when you're ready. What I'm going to be talking about is about the children and families we serve, but it's also about us because it's about all human beings. You'll notice there's a list of many problems that we encounter on a regular basis. And the number of problems really can seem overwhelming. And we often deal with them separately, but I'd like us to consider whether these seemingly separate problems are actually connected to each other. We often focus on what we can see, the tip of the iceberg. And what we've learned through this science, and actually for hundreds of years before that, before it got buried, is that there's a lot of stuff underneath the surface that's actually influencing what we can see. And if we can know about or explore or be curious even about what's going on underneath the surface, we can get some great guidance for how to help ourselves and help others. So we're going to come back to this later. This is a sample case, and it is of a little girl named Elena, of course, not her real name. She's 8 years old, and she's referred to the school health center from school. She has behavior problems at home and at school. She's very impulsive and easily distracted. She fights with other people. She's in the 3rd grade, but she's really functioning at the 1st grade level. And so her teacher recommends clinical evaluation. I'm sorry for the MD here. I know many of us are not. So hats off to nurse practitioners, physicians assistants, and all clinicians. But the teacher recommends a health evaluation and maybe even special ed services. And when the teacher has spoken with the mother, she's learned that the mother is experiencing a bunch of things at home, temper tantrums, nightmares, and that Elena's had been sick a lot with ear infections. Sometimes she eats, sometimes she doesn't. She's having trouble with constipation and incontinence, which is showing up at school also. So we're going to come back to this a little bit later, and we'll talk about Elena in the context of some of the things that we're discussing today. We're going to be exploring the connection between life experiences and health, both from an epidemiological perspective and also from a neurobiologic perspective. We're going to talk about screening, care planning, and treatment. We're going to go back to our case, and then we'll have a Q&A. And these are our objectives, which Shamika just went over for us, so I'm going to skip over this slide. And let's get into the epidemiology. So first, let's talk about what are adverse childhood experiences and when did this work begin? Well, adverse childhood experiences referred initially to 10 experiences of abuse, neglect, or household stress. And the work began in the 1990s. The first paper was published in 1998 and was a collaboration between Kaiser Permanente, a health management organization in California, and the Center for Disease Control. And this was what the study was. The study wanted to answer 2 questions. The first question was, how common are these 10 experiences before the age of 18? The second question was, what relationship do these experiences have with adult physical health, mental health, and social well-being? And what the researchers found after creating a questionnaire with these 10 experiences and adding up the total number of yes answers, which is the ACE score, what they found is that ACEs are extremely common. I'm going to give you some statistics in a minute. That they're interrelated. In other words, if you said yes to one question, you were highly likely to say yes to more than one question. And that they are cumulative. And we're going to actually talk about this a little bit more in a minute. But what that means is that one sort of loads on top of another and increases our risk for poor health outcomes. The research actually also showed us how profoundly impactful having a history of adversity in childhood was. And I'm going to show you a list of many of the problems that have been associated with ACEs in women and children. And the most chilling finding of this study was that if a person reported having 6 or more of these 10 experiences, their risk for dying 20 years earlier than the average person was increased. Scary. Now, what I want to say here, and what we're going to keep going over throughout, is that ACEs are our history, but they're not our destiny. This is not a death sentence, but something for us to know and factor into how we think about ourselves and our own health, and also how we think about our patients. So this study actually has been repeated in all 50 states as part of the Behavioral Risk Factor Surveillance Survey, and also in many states as part of the National Survey of Children's Health. It's also been repeated in multiple countries and different populations. And what I want to give you is some statistics about adults and about children. So across the country, about 60% of adults say that they've experienced one of these things at least. And about 40% of children, either their parents or they report that they've experienced one of these things. What we know is that adversity affects both privately and publicly insured individuals, children, but 2/3 of those who have public insurance are affected. We know that they're common across all income groups, but 58% of the yeses are in low-income households. Unfortunately, children of color, particularly Black children, are disproportionately represented. 60% have had at least one of these experiences. So here's some of the items, some of the health conditions in children that we can associate with adverse childhood experiences. And you'll see them on the left. And they range from things that happen perinatally all the way into adolescence and adulthood. And you can see that they have to do with healthcare utilization and ability to adhere to treatment, and all the things that we see in the school health center. Problems with eating and sleep, symptoms we can't figure out, difficulty in school, chronic disease, behavioral health, addiction, etc. And you'll see on the right, this is a representation of accumulation of the dose-response relationship of adversity with poor health outcomes. And basically what this diagram is saying is that the more experiences of childhood adversity we have, the more likely we are to be at risk for negative health and well-being outcomes. So this actually has great implications for us in terms of prevention, which we're going to talk about a little bit later. So what does this mean for the typical classroom? Well, the cutoff for what most of the research is done around is an ACE score of 4 or more. So saying yes to at least 4 of those 10 questions. Some people use 3, but if we look at the right-hand side of the little green box, and we just look at ACE score 3 or more, that gives us 13 out of 30 students in the average classroom will have actually a pretty high ACE burden, and an additional 11, so total of 24 out of 30 will have had one experience of adversity. So school children are carrying around a lot. And when we look at that list of conditions that are associated with childhood adversity, we can see what all is going on in a school that the children are contending with, that the school administration, teachers and staff are contending with, and that the school health services are contending with. Lots and lots of issues that need attention and care. So the ACE study was wonderful, but it left a lot of things out. One of the things I didn't mention was that the original study was done in people who were insured, who were employed, were mostly white and Hispanic, and they had a fairly high level of education. Now, subsequent studies have been done in other populations, and we know that those rates are fairly similar across populations. But what the ACE study didn't do is it didn't really explore experiences that are not happening in the home or at the individual level. It didn't really look at experiences in the community. It didn't look at structural experiences, and it didn't really look at historical experiences. And we know that all of these things actually have an impact on our health and well-being as well. And so we want to just keep those in mind. So things that were not studied in the original study were things like bullying and foster care, discrimination, poverty, slavery, Holocaust, war. And there are many, many, many more. And what I'd like to propose to you is that there's no list that's going to be complete. And so we really want to think about exploring these kinds of issues for ourselves and for the people that we're caring for in an open-ended way. And we're going to talk a little bit more about that a little later on. So let's switch gears. Not only do experiences of adversity matter, but positive experiences also matter. And in fact, some researchers are showing that these experiences might be even more important than those adverse experiences, particularly early in our lives. The Center for Disease Control has identified safe, stable, and nurturing relationships as crucial in both preventing and mitigating the effects of child maltreatment, and also promoting health, healthy habits, and healthy lifestyles. And you'll see here on this slide that there are many, many things that help to protect us. One we don't have control over. For example, we don't have control over when we turn 4 or more. The reason that this is on here is that actually the older we get, the less at risk we are for adversity. So again, not under our control. We all have to be 4 to be 5, and we have to be 1 to be 2, but just something of interest to notice that our youngest children are the most vulnerable. But you'll see here things about relationships. You'll also see things about meeting basic needs, about housing, about support for parents, and so on. And going back to the safe, stable, and nurturing relationships, what the CDC means is safe means free from fear and secure from psychological or physical harm. Stable means predictable and consistent. And nurturing means available and sensitive to respond to the child's needs. So their physical needs, their developmental needs, and their emotional needs. And we're going to go into this in a little more detail shortly. What the research shows is that the number, quality, and stability of relationships is a strong predictor of children's and adults' ability to survive and thrive. So just as ACEs have a dose-response relationship with health conditions, so do PIECEs, or positive childhood experiences. And what we learned in the last several years, people have been focusing on this more, is that the more positive childhood experiences we have, the better our mental and physical health. That in fact, we have a lower risk of any psych condition, doesn't matter the diagnosis. And we have a lower risk of any physical or mental health condition at any age, from birth, cradle to grave. And this is an interesting one too. There's a lower risk of chronic pain in children and adolescents. The reason that I don't have more details like I do on the ACE slide is that this research is just emerging. And I think we're going to learn a lot more about how important positive childhood experiences are. So the take-home point is that each person really has a complex combination of experiences, both positive and adverse, and they all matter, although the ones that have the most impact are those that happen the earliest in our lives. So really from late in pregnancy through the first couple of months postpartum. Again, that doesn't mean that we call it a day. It just means that those moments are very, very important. And so we want to really organize ourselves as a society to really support families and children at that time, although support is good whenever we give it. So we're going to switch gears for a minute, and we're going to talk a little bit about neurobiology and try to understand a little bit more clearly what the pathway is from experience to illness across the lifespan. And you all may be familiar with this pyramid, which is a modified version of the ACE pyramid. So childhood adversity towards the bottom, leading to disease, distress, et cetera, and early death at the top. This has been modified to add experiences that we have at structural, community, and historical levels. And what we're going to focus on in this next section is how adverse childhood experiences disrupt neurodevelopment with social, emotional, and cognitive and physical impairment, and also how positive experiences support neurodevelopment. So this is a very busy slide. I'm sorry, but you'll like it at the end. It's a good representation of what's going on. So we're going to go over it one piece at a time. So what you'll see first on the right side is what's supposed to be a brain and a body. And you'll see that the brain and the body really are one unified system that are connected physically by the automatic nervous system, and also all other body systems. And that's what those arrows are representing. The other thing that the arrows are representing is that the brain and the body are in constant communication in both directions, and they send electrical, chemical, hormonal, and other signals back and forth. The reason? To make sure we survive and reproduce. That's what all the signaling is about how to adapt to the environment, internal and external, so that we live. The messages or signals that the brain and body send are influenced by experiences that are occurring inside and outside the body. So our senses and the peripheral nervous system perceive those experiences that are happening outside the body and send those perceptions as information to the brain via the brainstem. And then the autonomic nervous system sends information from inside the body back to the brain. So we are a unified system, brain and body, and we are also part of the universal system with the world through our connection via our senses to the experiences that are happening outside us. So what we know is that all body systems, with a focus on the autonomic nervous system, function in cycles of arousal and activation, followed by calming and settling. And really, we can understand this diagram to represent the cycling in all body systems between on and off, or more and less activity. And so a healthy brain and body can move flexibly between activation and rest in response to stimuli, and send signals back and forth that promote repair, balance, and growth. We call this a balanced brain body, or a regulated brain body. And so regulation really is our ability to sense and respond to what's going on internally and externally to maintain a stable brain-body environment. And so brain-body regulation actually can be assessed without using anything fancy or formal. We don't need any blood tests or x-rays or anything like this. And we often think about this stuff related to ourselves, or we ask these questions just as part of our assessments when we're caring for children. And so how are they sleeping? How do they wake up, or how do we wake up and fall asleep? Are we able to tell what's going inside our body and we're not too bothered by it? Are our emotions in balance and mostly positive? Can we pay attention and concentrate? Are we able to get along with others and resolve our differences? And can we remember without being overwhelmed by our memories? And so a lot of times this will just come out in conversation, or certainly in an assessment, without really any fancy tests. If people are reporting that they're having trouble in one or some of these arenas, we know that their brain body is out of balance. And we're going to talk a little bit about how we can help them get back in balance and help ourselves get back in balance too. So we learn regulation. When we're babies, we come out and we're kind of at the whim of the wind. We can't feed ourselves. We can't clean ourselves. We're really dependent on others. And part of what we're dependent on in terms of others is to interpret the world for us and care for us and support our needs. And what you'll see in the left-hand picture of the mom and the baby is that they have eye contact. The baby looks like it's smiling or maybe making a little noise. And the mom is seeing it, understanding what the baby is doing, and then expressing something back to the baby. And it almost hard to tell if it's a diaper change or just the baby is lying wrapped in a blanket, but the mother is attending to the baby's needs. And this actually gives them both pleasure. That process that I just described to you is called attunement. And attunement actually supports attachment, strong relationships. And what we know is that actually throughout life and across many relationships, both attachment and attunement help us co-regulate each other, even when we're talking about two adults, but certainly with adults and children. And this attachment and attunement really helps us rest, repair, have fun, and grow, whether we're parent and child, teacher and student, doctor and patient, friends, or romantic partners. And this is really at the root of health and well-being, or disease and distress, is what has happened for people in terms of their attachment relationships. So let's talk a little bit more about positive experiences and how they can enhance regulation and health. We talked when we were discussing the CDC recommendations about positive experiences. What are some of the characteristics? And it's worth repeating here that the experiences that are positive for us, that help us enhance regulation, resilience, or the ability to bounce back in health, are those experiences that are predictable, that are mild or moderate, that are controlled or controllable, and that match our abilities. And we can also characterize these experiences as, well, let me tell you that with activities. So let me describe a little bit more. So we have things that we just do as human beings that help support regulation. One of them is sleep, and that's probably the most important one. We're social animals, and so relationships are a big part of what regulate us. And daily routine. And all these things really help to regulate the stress response system and brain-body synchronization. Some activities also are very regulatory. So any kind of contemplative activity like breath work, sports, art, mindfulness and yoga, playing outside, certainly meeting people's basic needs help them to stay regulated. And child psychiatrist Dr. Bruce Perry identifies 6 common characteristics of regulatory activities. He says that they are rhythmic, they're repetitive, they're relational, they're pleasurable, they match our current development, and they're respectful of our culture and of each individual and their community. And so you can see how many of these activities are very well described by those characteristics. What we also know is that these processes and activities work best when we engage in them regularly, and in the right dose for us. So like, I might need to go for a walk every single day, whereas somebody else might not. They might find that journaling and washing the dishes are the things that regulate them. So on the other side, we'll talk about adverse and traumatic experiences, and they really can impair regulation and health. And these experiences are characterized as unpredictable, as severe, frequent, or chronic, as uncontrolled or uncontrollable, and as experiences that overwhelm our abilities. And these are the kinds of experiences that cause imbalance, vulnerability, and disease. And so this is the kind of healthy system, the green, with an imposition of what potentially can be difficult experiences. And so what we see is when we're operating in this kind of zone of just enough activation and rest and not too much, and a nice balance between the parasympathetic and sympathetic nervous system, this is really the range for health, for creativity, for relationships, for well-being. However, when we have experiences that knock us out of this zone, they're too much or too little. So let me just give you, they are adversity and trauma, or they are neglect and deprivation. We can get stuck on too much arousal, on with many, many symptoms, both physical and behavioral health. Or we can get stuck on off, also with many symptoms, or we can kind of swing wildly between both of those poles because we can't regulate ourselves. And if we are kids and we don't have safe, stable, nurturing adults, they can't help us get regulated. And this situation of dysregulation is fine for a short period of time. So like, we see a bear, we run away, we calm down. Our bodies are designed to do that. We have about 20 minutes to stay in that kind of elevated zone, or about the same to stay in our disconnected zone. But then we need to rest and restore and recoup. And if we don't have the opportunity to do that, or the people to help us do that, and this goes on over and over and over again, it wears our brains and bodies out, it makes us sick. So this is kind of a summary slide. This is from an article in The Lancet a few years ago. It's a life course slide. And what it is sharing with us is that our life is really a complex interplay of biological, behavioral, psychological, and social, protective, and adverse factors that contribute to our health across the lifespan. What a life course approach does is it really describes health as cumulative, remember the ACE and PISA study, and longitudinal, with critical and sensitive periods. And it acknowledges that the broader environment affects health, and that health and equity reflects more than genetics, access to care, or personal actions. And so you'll see on the top in the green, this is the life course of somebody who's had many, many positive experiences. And the orange is the life course trajectory of somebody who has been burdened with many experiences of adversity and not enough positive experiences. And what I think is so impactful about this diagram is it really shows us multiple generations. So you can see that if we have an equity gap in the first generation on the left-hand side of the diagram, and we don't do anything about it. In other words, we don't give the next generation what they need to the degree that they need it, that by the following generation, that equity gap is even bigger. So I feel like, if nothing else, if we didn't already think this, it's really, really, really important for us to do whatever we can so that everybody has whatever their unique needs are met as much as possible. And I want to just add here, there was actually a pre-question that I want to mention here. Somebody asked, how many generations are influenced by what's happening right now? And the answer is 7. This is some wisdom from our Indigenous brothers and sisters that whatever is happening in the present will have ripples 7 generations from now. So I'd like you to just pause for a second. I've been talking and talking and talking. I'm going to stop talking for a minute so that everybody can breathe and just look at this beautiful orchid. The reason I chose the orchid is because the orchid can survive and thrive and adapt to conditions from Siberia to the desert. So let me be quiet for 30 seconds and let everybody take a breath. And we'll come back. I put this in because we need to take a breath often throughout the day. This is one of the ways that we regulate ourselves, and I thought we might as well practice that in our webinar as well. So now we're going to talk about application. What do we do given that we know, excuse me, that experiences, just take a sip of water, influence our health, excuse me, across the lifespan? Well, we learned how important meeting basic needs are, feeling safe and secure, and having positive relationships are in terms of both preventing adversity, but also mitigating it and buffering it should it happen. We also learned that there are a number of inborn processes and activities that we can engage in that help us stay in balance. And so these are really the things that we need to focus on for ourselves and for our patients. This is just an essential part of our care. And this is true whether we're a healthy person coming in for a checkup, or whether we are a newly arrived immigrant, or whether we're a foster child, or whether we're somebody who has multiple physical and mental health challenges. This is the foundation. The rest, I know you'll think I sound a little crazy. The rest is really gravy. This is really, really where the rubber meets the road. So this, we can weave this into all of our work and into our lives to really help us be as healthy and happy as we can be. Okay, so let's talk about some examples. So this is a long list of things that serve as primary prevention and also mitigation. And remember, we said positive experiences are super important. So what we want to do is accentuate the positive. So food programs, housing first, green spaces, community health centers, medical legal partnerships, perinatal home visiting, midwifery care, lactation support, parenting education and support, trauma-sensitive schools, which we'll talk about a little bit more. And then, of course, lots and lots of opportunities for all of us to have movement in our lives, to be able to engage in creative self-expression, and also time to reflect on our lives, not running all the time. Let's talk a little bit about secondary prevention. Many of you are interested in what we should do about screening. And I'm going to give you a few options. There's been a big controversy around this question of whether we should screen in the clinical setting or not. Most of the experts recommend not screening in the clinical setting. The ACE questionnaires were developed actually to learn about population prevalence. And as I mentioned early in the session, our our experiences in childhood are our history, particularly the adverse ones. They're our history, but not our destiny. So if you knew my ACE score, you wouldn't necessarily know about me. You just might know some possibility of me in a whole population of people. So what's the best way to ask questions so that you can learn about Audrey or your patient or yourself? Well, here are 3 options for sensitive trauma inquiry. The first is using an approach that we call universal precautions, and many of you probably remember about that related to caring for people with HIV. But what universal precautions is just assuming that anyone that we encounter has challenges and may have some history of adversity. Why can we do that? Well, we know that the rates are very, very high. So if we assume that, then we're going to just treat people with extra gentleness and care, regardless of who they are. And if we do that, they also may choose to disclose things to us over time as we have a relationship. We can notice how they present. Remember, people who have a high burden of adversity have multiple medical problems, severe medical problems, mental health and medical problems. They may have unexplained symptoms. They may have difficulty getting themselves to the clinic. They may not follow our instructions, that whole list. So if that's what you're seeing, guess what? You already know that they have a high burden of adversity and not as much positive experience as they need. The final is to ask open-ended questions. A very simple one that doesn't seem to bother people too much is to ask about their sleep. Sleep is something that gets disturbed actually early on with adversity and not enough positive experiences. And many people who've had a big burden of adversity will tell you things like, I've never slept well, or I'm afraid to go to sleep. So this is a way in without asking super sensitive questions. The other thing that you can ask about is just simply, how's growing up been so far? Mostly okay or pretty difficult? Most people are comfortable, kids too, answering this question. And then you can say, if they say either answer, tell me a little bit more about that if you'd like. If they say, I don't want to talk about it, then you say, that's fine. I'm here if you ever do want to talk about it. I'm interested in learning from you. So these are things that we actually can do. I know all of you are doing the thing in the left-hand corner, which is basically accepting non-judgmental care. But what we also see is some other things that can happen in the health center or in the school. And we see this adorable little girl practicing yoga. We're going to talk about that in a minute. On the bottom, we see people dancing. That really represents the arts, which are very accessible in school and certainly are things that we can support and sponsor from the health center. And then on the bottom, this is actually probably better for slightly older children, maybe, I don't know, 9, 10 and up, although you could try it with drawing with younger children, but it's journaling. There's a huge amount of research supporting the positive impact of journaling on healing trauma. This is something that can be done in the health center as a group medical visit. It also can be done in schools. So I want to show you a couple of studies and programs, and then I'm hoping we can get back to our case. This is an incredible body of work by a psychologist named Gene Brody from the University of Georgia. This is one study that's part of his whole lifetime of work. I highly encourage you to look into Strong African American Families, which is his program. But what this slide is showing is some outcomes compared between adolescent boys and whose families participated in the Strong African American Family Program, which is basically a parenting support and education program that was offered to Black families living in the rural South. And what they measured was the difference between the development of prediabetes at age 25, depending on whether the boys had participated in the Strong African American Families Program or not at age 11. And the top line is the control group. So that's the boys who then were men who developed prediabetes at age 25. They had not participated in the program. You can see the dotted line is those boys who had participated in the program. And what you'll also notice is that this program made even more of an impact for the boys than men who had a high burden of ACEs. On the bottom axis, you can see the number of ACEs, and there was a huge difference between developing prediabetes as a young man for boys who had a high ACE score but didn't participate in strong African-American families and those who did not. So incredibly, incredibly powerful work. Okay, now let's talk about some things that schools can do. All of the programs on the left are things that were developed to be used in schools. Calm Classroom is one, Quiet Time is another. Both of these are meditation practices. Mindful Practices is a yoga curriculum for schools. And BAVX is balance, auditory, visual exercises, actually bounce juggling, all developed for use in schools. And here's some of the results. So for Calm Classroom, there were 6 schools matched by academic standing, income, and race, and then 148 control schools. This was mindfulness meditation for 3rd through 8th graders. They found decreased misbehavior by about 23% versus an increase in the schools that did not receive Calm Classroom. The teachers also reported calmer students. The students themselves reported that they were more focused and ready to learn, and the teachers reported that they used it themselves and they had significantly decreased stress. So this is an amazing movie that's available to stream. It's about an alternative school in Washington State. It was the last stop before kids got kicked out of school completely. What this school did was they learned about the science of trauma and healing, and then they infused it in all their work. Lots of relational work. They had art, they had movement, and lots of counseling and care. And in school time in as opposed to suspension. What they found was they were able to decrease their suspensions by 85%, their grades and test scores went up, and their graduation rates increased from 18 to 80% over the course of about 5 years. So I'd like to read you this if I could. This is about a school that had a number of children who were homeless. And what they did was they converted their gym to a place for children and families to sleep so that they could arrive at school ready for school. So students without a safe and reliable place to sleep at night are more likely to be referred for discipline. They're more likely to attend schools with concentrated poverty. They score lower on testing. Students experiencing homelessness are also less likely to graduate high school and less likely to go to college. They're more likely to change schools and be chronically absent. For English language learners who are homeless, fewer than 9% are able to meet or achieve state standards in math. So a teacher at the school that hosted this sleepover said that before one of her students started sleeping in the gym, he usually arrived late to class and with no breakfast. He routinely missed the class's opening song and the preview. She tried to give him a quick recap and find some food, but it wasn't enough. He threw things, he tried to leave the classroom, and he hit other students. After he landed in the stayover program, he started going to sleep at 9 o'clock and he had breakfast in the morning. And she found him in my line and ready to go. She noticed a shift in his demeanor, happier, and behavior so much calmer. And soon the benefit of small group instruction and literacy interventions kicked in. So if you're not sleeping and you're not eating, you can't learn. The teacher said, the other day we were reading together and I was like, wait, did you just read that? So here's a child who went from being unable to read to being able to read because he needed a place to stay. All right, so let me tell you about this. We know, these are 2014 statistics, that in this country at that time, we would spend $1.8 million per person over the course of a child's lifetime if they had adversity. And when we invest in prevention, the savings are enormous. And you'll see here, and this is just a few strategies: parent education, coaching, home visiting, quality early childhood and education, and pre-kindergarten. We get a $6 return on investment. Well worth it. Well, let me see if I'm gonna show you just a couple things. I'm gonna blow through it and then I'm gonna stop so we have time for questions, but I'd like to show you a little bit about Elena. Let's circle back to her. So this is Elena. We talked about her before. She's got behavior problems. She also has medical problems, teachers referring to the health center. And as we looked at in the beginning, we could make this list of problems that seem to be disconnected, but now we know they might have some similar or the same root causes. What we would usually do is kind of label these things and send her somewhere for therapy, and maybe for psychiatric evaluation. We might give her a special diet, stool softener for her constipation and belly problems, and we'd possibly give her antibiotics for her ear infections. It's not that we don't do these things, but we also think, what could be going on and how can we affect that? So if we take a different approach, we might ask some of those open-ended questions. And in fact, this is what the provider did, and this is what we found out, that Elena and mom were living in Central America where they had good support, but they fled because of domestic violence and also attempted sexual assault on Elena. They had a very difficult journey. They were separated at the border and they were reunited, but Elena really didn't recover. And this is, of course, analogous to what many children experience when they're in foster care. They're separated from their parents and they're in this totally new environment. And this is when Elena's problems really began to escalate. And so this is a life course chart. You literally could do this on the back of a napkin, but you can kind of write out the experiences, both positive and adverse, that happened in various time periods. We know that the beginning for Elena was pretty regulated, and then things really kind of got enormously disrupted when she was in early elementary school. And so I just want to compare. On the one side, we've got this list of 8 problems, which is what we usually do. And again, not that we don't make that problem list, but if we recognize, again, that this mother-child dyad had really strong early attachment, that they had significant adversity that impaired regulation for both of them, but they were able to stay connected except for that separation, that this really is the underlying cause of what we're seeing with Elena. And so we might make a plan. If we're seeing just kids, we would make Elena's plan and we would use our care coordinator, our community health worker to help mom get connected also to her own care. If we're seeing, across the generations, we can actually work on both. We want to make sure that they have their basic needs met, and we really want to focus on repairing attachment, because this is going to be the thing that is going to help both mom and Elena. And we want to make sure that they're sleeping, because of course, when you're not sleeping, it really makes us all crazy and don't feel good. And then of course, we can add a lot of these things over time as needed or not. So this is what the school can also do, and what we can do with the school is we can address any pressing concerns of the teacher. We can share the science about the impact of experiences on health and behavior, and I'll talk a little bit about that in a minute. We can consider inviting mom into the school so that she's around, and we can really consider an evaluation for 504 IEP. And so what we want to do is open our minds and think differently, We want to balance our focus on strengths and problems. We want to look for root causes and follow development. We want to really focus on meeting basic needs, engaging in regulatory activities, supporting positive relationships, and making time to reflect both for our patients and ourselves. So I'm going to stop here. I hope we'll have a few minutes for questions. I really appreciate your attention and I look forward to chatting a little.
Thank you, Dr. Stillerman. Thank you for a wonderful presentation on adverse childhood experiences among school-aged children. And we do have a few minutes for questions. So if you have any questions for Dr. Stillerman, if you can please type them in the Q&A box, please.
And while you're gathering those, Shamika, I'm going to just touch on a couple things that folks sent in. The first is one person asked, how do we share info with people that might not be in the school health center? There's some resources that I have given you guys that'll be sent out when the link to the webinar are sent out. There's a bunch of websites at the top of the page that have all kinds of resources for sharing. So I would suggest that you take a look there. The other thing that people have done is they have done a book study together, or they've shown a film, they've shown a TED Talk, and the film that's in these slides, Paper Tigers, is a terrific school film. It's a little long, but it could be shown in sections. There's also some terrific TED Talks that don't take very long, but are great jumping off discussion points. And then I think, Shamika, I'll turn it over to you for other questions.
Yes, thank you, Dr. Stillerman. At this time, I do not see any additional questions, but please feel free to contact Dr. Stillerman. She has provided her email address as well as the School-Based Health Alliance. I think one question did come, but I'm not.
And while you're doing that, I don't know if this person is here, but somebody asked a question about utilization, fears about utilizing healthcare services among people who had a high burden of adversity. I don't know if that person is still here, but interested, if you wanted to type into the chat a little bit more about your question, we'd be very happy to answer that.
Thank you. So again, thank you, Dr. Stillerman. Before we conclude today's webinar, I wanted to share with you that the 2024 National School-Based Healthcare Conference is taking place in Washington, D.C. from June 30th to July 2nd. Registration is now open, and for more information, please visit the School-Based Health Alliance website. We also invite you to stay connected with us through our bi-weekly digest, as well as following us on social media platforms. Again, Dr. Stillerman, thank you for a wonderful, wonderful presentation today. It is greatly appreciated. And thank you all for attending today's webinar. We now invite you to complete an evaluation of today's webinar for us, please. And also to share that a copy of the recording and the PowerPoint slides and resources will be available on the School-Based Health Alliance website, the Health Center Resource Clearinghouse website, and also you will receive those by email from the School-Based Health Alliance in the upcoming days. Please feel free to contact the School-Based Health Alliance if you have any questions, as well as Dr. Stillerman. Thank you all and have a good day.